I had a question mostly for the single-payer person. I don't really understand exactly how your solution would work in this respect, but one of the things that always concerns me about single-payer is that it represents this one place for entrenched players to influence, to prevent innovation. And so, since we all probably like new treatments for things that we have, how do you think that you would put in place structures that would keep the person who invented the 10-year-old hip replacement or whatever from saying, no, that new one, don't pay for that one?
It's a very good point for this audience.
Yeah, that was for the MIT audience.
Yeah, no. You know what? My husband, who's an MIT alum also, this is where he and I kind of get stuck in debating this stuff, is that he argues, and I think he may be right, that part of the reason Canada works is that if you really want the fancy hip replacement, you can just go to the U.S. and pay for it, if you have the money. And so maybe there's a model in which then everybody goes to Merida for the really fancy titanium hip replacement if the regular one isn't good enough for you. But yeah, anytime you talk about a single payer system, there is a lot of risk of kind of the regulatory capture would be the kind of the economics term, or the regulatory economics term is regulatory capture, where either you've got all the pharma companies paying off all the people who are on the board of Medicare to approve blah, 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 or the FDA or whatever, or you have such strong pressure coming from the taxpayers that you don't approve things that maybe are a minor increment but pave the way for the big win. And that's an opportunity cost of never, you never know what you didn't have. The United States is spending, what are we at, 14 point something% of our GDP?
16 plus.
16 plus.
It'll be higher this year as the GDP goes.
As the GDP drops. Yeah. Basically, all the job growth in the 2000s was healthcare. All the job growth that we have had this decade has been healthcare at this point. There was construction and housing in there, but I think that just is evaporating real fast. So there's a huge sector of our economy, and there's a long line of research, a lot of which Dr. Luft pioneered, that indicates that a factor in that is that you have all these organizations that want to adopt the coolest, latest technologies at the same time everybody else does. How many special brain tumor zappers do you need in one city? Because we have at least 2 that I know of, and some, and maybe more. How you get into what people call the medical arms race. You get into the imperative for innovation, so that the only innovations that are awarded are the cost increasing ones, because nobody cares about the costs. And that's, so that's the, with a realignment of the financial things, yeah, maybe you lose there is some risk that you lose the big innovation that costs you gazillions of dollars, but maybe you actually result in incentives that produce the innovation that ends up saving money and saving lives at the same time, which is not where all the incentives point at this right now. So yeah, maybe.
But they both seem like maybes, and you've definitely created
it's all maybes.
That one person wants to go like this, and the big person that gets there first, no one else gets the cake.
So the fundamentals of economic, well, I mean, that's the regulatory capture, but one of the fundamental tenets of economics is we, as economists, we don't know how to make a lot of money in the stock market, because if we did, we'd both be retired by now. Economics is about the study of the allocation of scarce resources. We have a limited amount of resources in this world. We have a limited amount of time. We have limited money. We have to decide how to allocate it. So the whole world is a big pie, and we're putting 16.1% of our chunk of the pie into healthcare. We could make that 25%. And I'm not sure I'm the one to say that we shouldn't, but I think that's a big debate we want to have, whether we want 25% of our economy in a service sector healthcare when our outcomes are no better than any other industrialized nation in the world. In fact, worse in a lot of metrics. So, while I'm sympathetic to the technology thing, being...
Do you know what percentage of innovation in care, drugs, and therapeutics comes from the U.S. as opposed to from the rest of the world?
Just repeat that question.
What share of healthcare innovation comes from the U.S. versus the rest of the world? Any guess? I mean, there's a lot of European innovative companies too, but I think the question should be, if they couldn't sell it to the U.S., would they do it? Right. So I
Driven by the U.S.
who knows?
Harold, did you want to come? Okay. Okay, we'll just have a couple more questions. I know it's getting late, but I think there's a few people. I'm just going to, this woman back here.
So the way I see the two proposals are that for most parties are these are more or less cost distribution issues. So what do you think of cases when, now it's tied in with the previous question, when we have new innovations, new medications that have potential to really make a difference in someone's life but cost a lot. There's a lot of new biologics coming out. They cost a ton of money, but really make a humongous difference. So assuming that it's not a fixed pool of money that we have to redistribute, but if the cost truly is increasing, how would you deal with that question of how to deal with increasing costs in healthcare instead of redistributing the amount of money that we have so far?
To some extent, I think you're raising the issue. Joanne had mentioned earlier the problem of when will we really face up to the question of rationing? And so if there's a new biologic or a potential biologic that can extend somebody's life, and let's say with good quality of life, not just extended another couple of months and being really miserable, do we put our resources into that? I can't really answer that question as an economist. I think there are so many more choices and decisions that we can make before we have to get to that rationing question. There are so many things that are being done that provide no useful information, no real benefit. Let's focus on those first. Now, it is true, and this goes back to the previous question, if one changes the incentives, then I think the rate of growth in technological innovation will change and the focus will shift. The focus will shift more towards real quality enhancing cost constant or cost reducing quality constant. And so there may be fewer of those new biologics. There may be people then who will die who otherwise would not have died, but there'll be many, many more who will get good at healthcare or better healthcare at the same cost. Those are alternative scenarios. And I'm saying if you want to put more money into those new potential breakthroughs, you can still do it. But right now, there's nobody running the train.
So let's build a model of increasing costs. How would you deal with that in your model?
The question is, how would I build into my model increasing cost issues? Right. Right. So for example, in my little model, everybody gets the gold plan coverage, which is really, really pretty good. Some people demand platinum. Okay. And the analog here is the way we've seen innovations in automobiles. Side curtain airbags first went in to the luxury cars, the Lexuses. People started saying, this works. You now get them on all cars. Anti-lock brakes started, all at the very high end, and then they filtered down. So the platinum coverage, which only a few people will say, I want anything that I demand, even though it hasn't been proven to be healthy and helpful, they'll get it, and then we'll see if they do better. And then as a society, I would argue, we ought to cover it.
Aren't those examples of exacting sort of single payer for automobiles? Wouldn't have paid for side curtain?
Well, either wouldn't have or absolutely would have if it was made in the right congressional district.
Right. No side curtains, but butt curtains or something.
That's right. So that's where a single payer system has a problem, where it's too open to political influence one way or the other. It is not sensitive.
Okay. We've probably got time for one question. This gentleman back here has been waiting very patiently. So we'll take the one question, then we'll kind of summarize. And I've got some questionnaires I'd like, if you have time, to fill out. Here you go, James.
Yeah, I have one comment and a follow-on question. I mean, one of the things I I appreciate discussion in terms of if you actually had all, if the fairy godmother actually showed up and gave you the option between the two plans, actually both are actually very workable. What's worrisome to me a little bit is the fact that I've never met my fairy godmother, and just from a Silicon Valley standpoint, any change that's too revolutionary in nature is typically a non-starter when you're talking about politics, when you're talking about legal concerns, when you talk about anything of that sort. So anything related to things that actually make sense and work and actually benefit people has to, in my mind, has to be very evolutionary in nature. We have to have steps to actually move us in one direction or another. One of the things that actually came in mind is that, the fact is we do actually have a Medicare system that works, that covers a vast number of people on a nationwide basis. And even though, admittedly, there are definite issues with that system, it actually is a system that covers it. The thing that I'm actually not sure about is why is it that no one's actually ever suggested kind of an opt-in nationwide program where the government would actually provide some type of opt-in option, kind of like Medicare. Or for example, I could actually sign up to Medicare as opposed to a Blue Cross Blue Shield system. And the government would actually act as a PPO on my behalf. I mean, it seems like a very simple thing to do. It seems like something that could actually be workable. And I'm trying to figure out, is it political or issues that actually are stopping that from happening? Or is it just because nobody really wants to go there?
I think this is kind of nice. It gives you a little time to think about the answer. Whoops. Who would like to take that first?
Well, I'm finding that intriguing, the idea of Medicare as an opt-in, that you could choose to buy Medicare instead of what else your employer offers you. Medicare insurance is generally less expensive than private insurance. Now, partly because that's probably because doctors aren't paid as much, and I mean, there may be some negative sides to that. But that's an intriguing idea as an incremental step. Another variant on that I have heard proposed many times is, shouldn't every American have access to the federal employee health benefit system? Or if all of us had access to buy into CalPERS? And now in CalPERS, you get a choice of plans. You get subsidized for up to the value of the least expensive plan. If you want to buy the more expensive plan, you pay every extra dollar that more expensive plan costs. So you have an incentive to, do you really value that more expensive plan? UC is structured that way, so is Stanford. Alan Enthoven had his hands in all of these programs. So these kinds of models are potentially incremental. I think what I'm finding interesting right now is the question of expanding health insurance to children, because I think most Americans can agree in principle that children should all have health insurance. And from a practical standpoint, it's pretty inexpensive to cover them. But right now, it's such a political football how to do that. It's been through the state children's health insurance program that's kind of the evil twin of Medicaid, and we know Medicaid's underfunded. And the S-CHIP programs they've had, a lot of them have been good. A lot of them run through private insurance companies. They're subsidized, but they have problems getting enough kids to enroll in them. They've had problems with changes in federal policy that make it hard for states to expand their programs and so on. I don't know how come it hasn't been said, hey, Medicare, why don't we make it for the poor and or for children and adults? And that would be an incremental step. And actually, if Hal's policy, now maybe I'm reading it wrong, the catastrophic component of the health insurance that he proposes is also could be Medicare Part A, or a variant of that, where there may be a way incrementally to step into a proposal like that, where you say, we're not going to do the physician insurance component of Medicare, and certainly not the prescription drug portion for everybody, but we'll do the hospitalization portion of it for everybody. But then we're going to revamp it in certain ways to make it more efficient, and that may be an incremental way to go in that direction.
At least as I see it, the issues are not technical, they're political. Political both in the Congress and political in getting people to make changes. If you had the ability to voluntarily opt into Medicare, at what price would it be? because after all, Medicare is oriented around people who are 65 and over. So how does one figure out what that price is? And then once you set that price, the people who will opt into it are those who are sicker than average. So you've got a real risk adjustment problem there on that part. The second part, as was mentioned earlier, Medicare is a monopsony payer. They don't pay very well. Hospitals, they pay okay. Physicians, it's the pits in terms of the Medicare part. And then you can't balance bill or charge anything above that. And so which physicians would be happy about their patients switching over from a not very good Blue Cross or Blue Shield plan to a Medicare plan? So part of what I'm trying to do, but you're absolutely right about how do you get change? How do you get from here to there, where it's a big chasm and you can't do it in 3 jumps? So part of an implementation plan that I've tried to work out is to say, let's start with the inpatient hospitalization piece and ask those physicians and hospitals who want to come together in a care delivery team, voluntary, voluntary, voluntary. They can do that based upon, and what they would get paid, at least in the interim, would be whatever they're being paid right now. And if Medicare rates go down in the future, which we can bet they will, because the Congress isn't going to raise taxes, they will be held harmless. Their rates won't go down. If Medicare rates go up, their rates go up. So we start giving them an incentive to join those care delivery teams. Of course, if they do that, the more who do that, the less money is left over for those who haven't joined the care delivery teams. And we start encouraging people to move in. So there's an incremental aspect. You could then have this universal coverage pool, which would actually, I would want to take over from Medicare, and says, we're not going to constrain what people charge. We're going to use this model. And then if Blue Cross wants to buy into our care delivery team model, they can do that at 3% more than what we're paying the care delivery team. After all, why shouldn't they make little money? And the insurers will then start moving into that. So I'm actually trying to build an implementation plan, a transition plan to get to where you want to go. I don't put all my faith in my fairy godmother.
But it is the case, though, there's an answer to that question that's been introduced in Congress, and the expansion of Medicare to allow people to buy into it has been blocked by one of the political parties which need not be named. One of the political parties which would like to do away with Medicare in the first place as a too much government blocked the expansion, the offering of Medicare in that exact way. The same party blocked the expansion of S-chip to expand coverage for kids.
Thanks.
The only reason why I mentioned Medicare is simply because they actually already have the technology as well as the payment infrastructure already in place. I mean, I'm not talking about inheriting policies that's already in Medicare. I'm talking about a government-issued PPO that really, in essence, would actually compete with industry. To actually have some type of evolutionary change to either a single payment system or managed care, management competition system. But we need the incremental step, or else we're never going to get there. We've been talking about the same issue for the past 15 years.
Longer. What James was just talking about is needing the incremental, and that we've been talking about this for 15 years. And we really need to be able to have an implementation step and a way of being able to move forward. And systems already exist that we can actually adopt. And why can't we make things work better and move towards something? We can't go from day to day. You can't go from 0 to 60 miles an hour in one step. And I think that's a really fundamental, is about how do we implement this and what trade-offs are we willing to do in order to make this happen. And the trade-offs will be different for different people. So how do we create a semi-consensus, or at least leadership, the leadership to drive this? Because it's going to take true leadership. And I don't mean from also from government, but also from individuals. And this is a room full of leaders. You guys are leaders in this. You're part of it. You're here. You're committed. You've stayed till 9 o'clock after a long day. You know, you are part of this. And I think that that's really what is inspiring. Is that, you know, that's what the Health 2.0 talks about, where it's the consumers that's going to make the change. But I think it's really more about the people who are really at the coalface of this problem, standing up and being part of the solution. And it can start in simple ways. And I don't think we're going to lose innovation. I think we're going to maybe shift where innovation is, but it has always shifted. So that's part of the entrepreneurial challenge, is to find solutions to go where the incentives are. You know, and to live with the trade-offs. We are going to have to make some serious trade-offs, or we're going to end up with the catastrophe that you're talking about, when that is going to be so painful we'll have to do something, and then we won't have the time to reflect to do it properly. And we have the time to reflect properly, but not wait too long. You know, we've done it for 15 years. You know, why can't we make that first step? And I think that's the key to our discussion collectively. And I would really like to thank Dr. Lutz and Dr. Sve for doing this. You know, and if I can get the names correct, I'll actually win tonight. So, you know, I do a lot of speaking, but occasionally I do get a little nervous. But the idea is that you guys have been fantastic at this, and I think that I really want to thank them for being welcoming your discussion. This has been a very interactive, you know, panel discussion, and I think that it's really been awesome to have you guys here. And thanks for stepping in for Jim, who was not able to join us. And I'd like to thank Michael and Kevin, who have been on our reaction panel, both doctors, have been part of this panel, part of this committee, and have really done an amazing job in trying to keep current and also providing their commitment to making a difference. So now the challenge is up to us. Right? What are we going to do next? How are we going to be part of it? What one little thing are we willing to do to make a difference? You know, and that's really what it's going to take. And, you know, I think that MIT alumni have that ability. And I just challenge this group to be part of the solution. And we welcome your input on that. And we welcome your comments. There's lots more questions out there, I know. These guys have emails. What's nice about university professors is you can reach them. So you're more than welcome to find them. And also we're looking at trying to set up a blog so that we can have this debate publicly. And we're trying to find a place where we can post that. And a couple of people are going to help with that as well. So we want to make this an interactive thing. We'd love to come out with an outcome at the end. But I just want to say, you know, thanks to everyone for being here, and thank you for your comments. And if there's anything you guys would like to summarize at all? Okay. Thank you very, very much. Please give them a warm thank you.